Patient is a 14-year-old white male with prior diagnosis of cystic fibrosis, chronic sinusitis, and ADHD who was admitted 4 days ago in acute respiratory distress after developing a severe cold with cough, congestion, and rhinorrhea 2 weeks prior to admission. He was diagnosed with cystic fibrosis at birth, for which he is prescribed Dornase alpha nebules, to which he is non-adherent as evidenced by his pharmacy refill profile. Symptoms of cough and congestion began 14 days ago, and he reports that he has gone downhill since. Also reported having 4 to 5 loose, foul-smelling stools per day, beginning 7 to 10 days prior to admission. 1 week prior to admission, he presented to his pediatrician with point tenderness over the sinuses and a low-grade fever, and at this point was prescribed ciprofloxacin and prednisone. Following initiation, he had minimal symptom improvement, increasing difficulty clearing pulmonary secretions, worsening respiratory effort, and a fever for 2 days at home. He was then admitted to the hospital 4 days ago by his pediatrician for IV antibiotics and was started on ceftriaxone at 1,000 milligrams and tobramycin 380 milligrams, both IV every 24 hours. The patient was noted this morning to have worsening fatigue, and he has not vomited with his current illness. Past medical history is significant for chronic sinusitis, with sputum culture positive for Pseudomonas aeruginosa infection confirmed 6 months ago. Other problems include pancreatic insufficiency as a result of his cystic fibrosis, for which he is prescribed Pancrease 10,500 unit capsule before meals, which was continued in hospital, and an 8-year history of ADHD, for which he is prescribed Metadate CD 40 milligrams daily, which has not been ordered inpatient. He has no known drug allergies. Upon physical examination, he appeared thin, frail, in obvious distress, and has a barrel-shaped chest. His blood pressure was 110/70, pulse 144, respirations 44, temperature 99.3, and O2 sat is 95% on 1 liter per hour. He is 60.5 inches tall and weighs 38 kilograms. He was positive for clubbing, dried mucus in the nares, erythematous oropharynx, and nasal polyps. Bronchi were noted bilaterally in the upper lobes of his lungs and have improved from baseline. He was also noted to be upset and uncooperative upon examination. His Chem7 showed elevated CO2 at 34 and glucose at 188. His CBC with differential showed a white blood cell count of 20.1 times 10 to the third cells per cubic millimeter, 26% bands, 6% lymphocytes, and 1% monocytes. Tobramycin peak was collected 2 hours after administration yesterday and was below goal at 19.8 micrograms per milliliter. Troph was collected at 0/100 today and was undetectable. Chest x-ray upon admission was positive for bronchiectasis consistent with cystic fibrosis, and sputum culture is currently pending. In summary, I believe the patient is septic secondary to a respiratory infection as evidenced by the bronchi in his upper lobes, tachycardia, tachypnea, and elevated white cell count. Recent prior history of Pseudomonas infection indicates the need for dual coverage antibiotics, and ceftriaxone unfortunately does not cover Pseudomonas, and therefore I would recommend discontinuing and initiating aztreonam 2 grams IV infusion every 6 hours over 30 minutes. I would also recommend increasing the tobramycin dose to 420 milligrams every 24 hours infused over 60 minutes, and drawing peak concentrations after the 3rd dose is administered to ensure it is within the goal range of 25 to 30 micrograms per milliliter. There is also no known clinical benefit of inhaled corticosteroids in cystic fibrosis patients. Therefore, I would recommend discontinuing his fluticasone 110 microgram inhaler in-home and at a hospital, and recommend initiating albuterol 2.5 milligram nebules 3 to 4 times daily as needed via nebulization. The patient's frail appearance, low weight, and chronic diarrhea prior to admission indicate uncontrolled pancreatic insufficiency, and therefore I would also recommend increasing his pancrease to 21,000 units before meals. The patient also requires dietary counseling, so I would recommend he consult with the dietitian and reevaluate upon discharge. I would also recommend ordering his Metadate CD 40 milligrams daily inpatient to improve his cooperation with exams. Thank you.